So today we'll start our discussion on cerebrovascular diseases. Over to Dr. Aravind.
Good afternoon, everyone. Today we'll be discussing about CVA. Sir, 1 minute. Sir,
Start.
Good afternoon, everyone. Today we'll be discussing about cerebrovascular diseases, uh, mainly about the ischemic stroke. To begin with, definition: a stroke or cerebrovascular accident is defined as an abrupt onset of a neurological deficit that is attributed to a focal vascular cause. It is the second leading cause of death worldwide. It is the second most common disabling condition in people aged 50 or older worldwide. They say time is brain. That is because neurons lack glycogen, so the energy failure is rapid in neurons. Uh, there is something called ischemic penumbra. It is defined as the ischemic, but it is reversible. Begin with pathophysiology of ischemic stroke. Just after arterial occlusion, there is ischemia. Ischemia leads to rapid energy failure in cells. Because of this energy failure, there is lack of ATP, so the ion channels will not function properly. So there is influx of calcium and sodium ions. So this again leads to proteolysis and membrane breakdown and cytoskeletal breakdown. This again in turn causes cell death. Uh, this calcium and sodium influx also leads to mitochondrial damage, which again in turn triggers apoptosis. It also releases free radical formation, which again in turn affects the cell membrane, again and causes cell death. So it is a vicious cycle that is going on. On the other end, it can also cause glutamate release through glutamate receptors, which in again causes ion channel disturbances. Coming to causes of ischemic stroke.
Pathway is actually very important pathway because this is not only a pathway pathophysiology describing ischemic stroke. This is in fact the pathway describing most of the metabolic encephalopathies. So to be in short, we can divide the brain into two systems, anterior circulation and the posterior circulation. Metabolically, they both are different. So the anterior circulation, they say it is more susceptible to all the triggers like ischemia, uh, hypoxia, hypoglycemia, all electrolyte disturbance. So the basic thing is the same. Here, what he has mentioned is any arterial occlusion leads to ischemia. Like basically, it's a problem with the oxygen consumption of the brain. So yeah, it may be hypoglycemia, or it may be low oxygen, or a low perfusion to the brain, whatever be the thing. The brain's energy consumption or the routine pathway which we learn in biochemistry, when that fails, there'll be hypoxia to the brain, reduced ATP of the brain. When ATP fails, sodium potassium ATPase pump, which is the main pump in the brain, fails. So when that pump fails, there'll be sodium retention in the cell. That is what is mentioned. Sodium and calcium gets retained in the cell. That leads to cell edema. Until this stage, it is reversible. Okay, so when there is energy failure of the brain and when there is cell edema, brain cell edema, till this stage is reversible. If symptoms are identified at this stage, be it hypoxia or ischemia, cardiopulmonary arrest, or metabolic encephalopathy, if you correct the inciting event, this edema will reverse and patient may go back to normal state. But if that cell edema persists, it leads to proteolysis, cytoskeletal breakdown, and leads to cell apoptosis, mitochondrial damage and apoptosis. From this stage, it will become irreversible. So that is how a stage of reversible encephalopathy goes into irreversible stage. All this I told is mainly about the anterior circulation. Once the anterior circulation cell completely goes for a cell death, I told you posterior circulation is a bit resistant to all these changes. Then the same changes will start occurring in the posterior circulation. That is when patient goes for a brainstem dysfunction, like a respiratory failure, and finally it leads to cardiac arrest. Right? So basically, any encephalopathy, including ischemic stroke, is concerned with failed oxygen metabolism in the brain, like failed electron transport chain, O2 deficiency, ATP deficiency, cell edema. Up to this stage is reversible, and then on goes to necrosis, which is irreversible. And please remember this point: anterior circulation is different, posterior circulation is different. Okay, let Aravind continue.
Okay. Moving on to causes of ischemic stroke. The common causes are thrombosis, lacunar infarcts. It can be large vessel thrombosis. Even dehydration can cause. Coming to embolic occlusion, can be an artery to artery cause or cardioembolic or even paradoxical embolus. Artery to artery, it can occur from carotid bifurcation, aortic arch, arterial dissection. Cardioembolic, it can be secondary to atrial fibrillation, mural thrombus, post myocardial infarction, dilated cardiomyopathy, valvular lesions, especially mitral stenosis, any mechanical valve, bacterial endocarditis. Paradoxical embolus can occur through pattern foramen ovale or atrial septal defect, atrial septal aneurysm, spontaneous echo contrast, and certain stimulant drugs like cocaine, amphetamine can also cause uh, ischemic stroke. Few uncommon causes are any hypertrophic states like protein C deficiency, protein S deficiency, antithrombin 3 deficiency, antiphospholipid syndrome, factor V Leiden mutation, prothrombin G20210 mutation, any systemic malignancy, sickle cell anemia, beta thalassemia, polycythemia vera, autoimmune conditions like systemic lupus erythematosus, homocytinemia, thrombotic thrombocytopenic purpura, disseminated intravascular coagulation, dysproteinemias, nephrotic syndrome, inflammatory bowel disease, use of oral contraceptives, even COVID-19 infection. Venous sinus thrombosis can also cause stroke, fibromuscular dysplasia, certain vasculitis like vaginous granulomatosis, Takayasu arthritis, giant cell arthritis, primary CNS vasculitis, meningitis, all bacterial, fungal, viral meningitis, even tuberculosis, and non-inflammatory vasculopathy like reversible vasoconstriction syndrome, Fabry's disease, angiocentric lymphoma, and cardiogenic uncommon causes include mitral valve calcification, atrial myxoma, intracardiac tumor, Marantic endocarditis, Liebman-Sachs endocarditis, subarachnoid hemorrhage, vasospasm, moyomyotitis, and eclampsia. Nearly 30% of cases, despite extensive workup, sometimes cause cannot be found out. So I would like to discuss about few uncommon causes. CADASIL, that is cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. It is an inherited disorder. It is caused by NOTCH3 gene mutation. It is characterized by small vessel strokes and progressive dementia, mainly in the subcortical level. Image shows extensive symmetric white matter changes. The onset is usually in the 4th to 5th decade. There is autosomal recessive form, that is CARASIL, and there is another entity called HERNS, that is hereditary endolipopathy, retinopathy, nephropathy, and stroke. Regarding one more cause that is rarely discussed, that is reversible cerebral vasoconstriction syndrome. It is a close mimic of subarachnoid hemorrhage. The patient will have sudden severe headaches that will peak within the first minute. Sometimes includes neurological deficits related to brain edema, stroke, or seizures. It is a non-inflammatory process. Cerebral angiography may reveal the classic sausage on a string appearance of a constricted cerebral arteries. Oral calcium channel blockers have been tried to some extent. One more rare disease is moyamoya disease.
Aravind,
Sir.
TA, you have a separate slide, right?
Yes, sir.
Okay. Okay, continue.
Moyamoya disease. Still, the pathophysiology is poorly understood. It is basically occlusive disease. It mainly involves large intracranial arteries. Vascular inflammation is usually absent. It is a slow disease. It leads to rich collateral formation. This on imaging leads to a puff of smoke appearance. It is common among Asian children or young adults. So this progressive occlusion leads to a large vessel distribution stroke. Extracranial bypass of the extracarotid carotid vessels to dura can help prevent a stroke, they say. Anticoagulation is risky in these patients as collaterals are fragile and can easily bleed, leading to intracranial hemorrhage. Regarding arterial dissection, intracranial vessels are more prone to arterial dissection when compared to extracranial vessels because of the thin adventitia. It may lead to subarachnoid hemorrhage or pseudoaneurysms. The exact cause of most of the arterial dissection is not known, but certain inherited disorders like Ehlers-Danlos, Marfan's, cystic medial necrosis, fibromuscular dysplasia are associated with it. Trauma and spinal manipulative therapy are also associated with arterial dissection. Most of them heal spontaneously. Stroke or TIA presentation is uncommon beyond 2 weeks. A few words about cardioembolic stroke.
Why all these vascular
Non-rheumatic.
diseases are important to know is like why to know about moya disease, why to understand that arterial dissection is an important cause of stroke is. Now the trend of management is changing from routine management to a thrombolysis. Now even thrombolysis is getting outdated. We are going towards an advanced treatment called thrombectomy. So previously, any stroke, ischemic stroke coming less than 4.5 hours, thrombolysis is the definitive treatment. And nowadays, the time window has been extended up to 24 hours. So any patient who come between that 4.5 hours to 24 hours time, we have another definitive treatment called as endovascular thrombectomy or stroke surgery. So, and one more investigation, which is very important in addition to doing a CT or MRI is angiogram, CTA angiogram or an MRI angiogram. Because of all these abnormalities mentioned, it is not enough only to know whether it is an ischemic stroke or an hemorrhagic stroke. It is also important to know about the vascular anatomy, whether there's a large vessel occlusion like a moya disease, whether there's a dissection, because in these cases, giving anticoagulation or thrombolysis can be dangerous and it can lead to more hemorrhage. So doing a thrombectomy can be safe in these situations, right? So that is why whenever possible, in addition to doing a CT, at least a CT angiogram or if possible an MR angiogram is needed to understand the arterial anatomy. Okay, continue.
Regarding cardioembolic stroke, non-rheumatic atrial fibrillation is the most common cause of cerebral embolism. They say dynamic CHA2 DS2 VAS score should be assessed, should be used to assess the risk of stroke in patients with AF. Mitral valve prolapse is usually not a source of emboli unless it is severe paradoxical embolism. That is, it can be a venous clot, a fat embolism, air embolism, or amniotic fluid. It enters from right to left via intracardiac shunt. Bubble contrast transthoracic and transesophageal echo can be used to pick up the conduit. If there are bubbles in transcranial Doppler insonation of the MCA, even pulmonary AV malformation uh, can be a cause if there is no intracardiac shunt present. So we
that
will
disease
discuss
is
about
called as a cryptogenic stroke. So as
this.
you mentioned earlier, in spite of the so many causes which you mentioned, the common causes, uncommon causes, hypercoagulable causes, vasculitis, there's still 30% remain undiagnosed. So one of the reasons why such stroke remains undiagnosed is because of this entity called as cryptogenic stroke. So PFO is one of the cause of cryptogenic stroke. That is, there is a shunt. Remember, shunt may not be open all the time. During times of some raised intra-atrial pressure only, it may open up. So that is how, yeah, from the right to left shunt opens up the PFO and it may cause a stroke at that time. So it is diagnosed only by this bubble contrast echo. Sometimes intracardiac shunt may not be present. There may be an intrapulmonary shunt like a pulmonary AV malformation as mentioned. So that 30% of undiagnosed stroke may be due to these reasons. If possible, we can evaluate them. Okay, continue. And remember, atrial fibrillation is the most common cause of cerebral embolism. But patients may not have atrial fibrillation when they present to you because patient would have had a transient atrial fibrillation and he would have reverted to a normal rhythm and he would have had another embolization. When in atrial fibrillation, during atrial fibrillation, the chance of embolization is less likely. But chance of clot formation is more during the time of atrial fibrillation. Once they revert back to the normal rhythm, then the chance of embolization is more because the power of the atrial contraction is gets retained to normal. That is why, while reverting a case of atrial fibrillation normally, always anticoagulation is first advised before going to rhythm control, right? You would have learned in cardiology. That is the reason because while in atrial fibrillation, the chance of embolization is less likely. Only when the atrial fibrillation occurs, a clot has already formed and they revert to a normal rhythm, the chance of peripheral embolization is more. So most of the time, even though the reason is atrial fibrillation, we may not pick up atrial fibrillation when they come. So always you try to find out whether there is any substrate for atrial fibrillation, like a dilated atria, background of heart failure, or any background valvular heart disease, which can prone them to cause or which makes them prone to have this atrial fibrillation. In that case, we can anticoagulate. So it is not necessary to have an atrial fibrillation while they come to you. And any case of atrial fibrillation, even though it is one episode of atrial fibrillation, when diagnosed anywhere, always try to give a stroke prophylaxis provided they fulfill the stats criteria or something. Okay, at that time they might have the thing, but next time just a single episode of atrial fibrillation means they are prone to get any stroke in future. Okay, thank you.
We will discuss about atrial fibrillation, TIA, and anticoagulation in further slides. Coming to stroke syndromes, having known the causes of stroke, the presentation is important to recognize early and do the needful. Stroke syndromes are broadly classified as large vessel strokes within the anterior circulation, large vessel strokes within the posterior circulation, and small vessel disease of either vascular bed. This is the pictorial representation of anterior circulation. You can see the internal carotid artery bifurcating into middle cerebral and anterior cerebral. You can see the middle cerebral artery giving lenticulate striate branches to the basal ganglia structures. This is the course of middle cerebral artery, which comes to the sylvian fissure and supplies both frontal, parietal, and temporal lobes. This is of anterior circulation. You can see it supplies the medial surface of the frontal parietal lobes. This is at the base of the brain. You can see the circle of Willis formation and its branches. This is the formation of basilar artery from two vertebral arteries and their branches, and it last gives rise to posterior cerebral artery and the structure supplied by it. So before going on to management aspects, sir, because I wanted to know about these terminologies, I have included it, sir. Some may be familiar with all these terms. Uh, Baragnosis, it is the ability to perceive or estimate the weight of an object by holding or lifting it. Word deafness, sorry, this is the inability. Word deafness, it is the inability to understand or repeat spoken languages in the absence of other language difficulties. That is, they may be able to hear noises, but words they cannot interpret. Then jargon speech, that is production of incomprehensible language containing frequent phonemic distortions, semantic errors, or neologisms. They feel the speech makes sense to them, but it is incomprehensible to others. That is what is jargon speech. Then we all know conduction aphasia. It is difficult to repeat words or phrases, but allows for fluent speech and comprehension. That is, they are able to understand. They will have a fluent speech, but the repetition is difficult. Then Gerstmann syndrome. That is, they have acalculia, alexia, finger agnosia, and right-left confusion. So all these syndromes and the lobes affected, I will be discussing in further slides. Just introduction to the terminologies. Apraktagnosia, that is inability to combine parts into a whole one. For example, like assembling toys. Then anosognosia, that is unaware or in denial of an apparent disability or deficit. Asomatognosia, the person feels like part of their body has been disappeared. Then tactile aphasia, as the name suggests, it is difficulty in naming the objects by touch, but they have the ability to name objects by sight or sound. Then verbal dyslexia or auditory dyslexia or dysphonetic dyslexia, there is inability to sound out words and map sounds to letters. Color agnosia or anomia, that is inability to name the color in the context of a normal performance on tests of matching color and of color generation. That is, they have difficulty in naming the colors. And prosopagnosia, inability to recognize faces. Topographic disorientation, that is inability to navigate the environment in daily life. Simultagnosia, inability to perceive more than one object at a time. Peduncular hallucinosis, it's a type of visual hallucinosis with vivid and colorful visions of people and animals. Metamorphopsia, as you all know, distorted or warped images. Teleopsia, the objects appear farther away than they actually are. Palinopsia, they continue to see an image after it's no longer there. Paresthesia, an abnormal sensation where spontaneous are evoked, but it's not pleasant. Dysesthesia is an unpleasant abnormal sensation, whether spontaneous or evoked. Anorthria, that is complete loss of speech. Abulia, that is delay in verbal and motor responses. Motor perseveration, that is repeating or prolonging an action. Anomic aphasia or amnesic aphasia or nominal aphasia or dysphasia, that is severe word finding difficulties, while fluency, comprehension, repetition are all relatively intact. So with this, I would like to talk about specific syndromes. Medial medullary syndrome, which occurs by occlusion of a vertebral artery or branch of a vertebral or lower basilar artery. So on the side of the lesion, there is paralysis with atrophy of one half of the tongue. This indicates ipsilateral 12th nerve is involved. On the side of on the opposite side, there is paralysis of arms, face, arms and leg, sparing the face. Impaired tactile and proprioceptive sensation over one half of the body. This is because of the involvement of contralateral pyramidal tract and medial lemniscus. You know, the lateral medullary syndrome, otherwise called Wallenberg syndrome. It can occur due to occlusion of any of the five vessels. Can be vertebral artery, can be posterior inferior cerebellar artery, or superior, middle, or inferior lateral medullary dysphasia of limbs and falling to the side of lesion. Uh, uh, this can be due to cerebellar fibers or cerebellar hemisphere structure itself. Patient may have nystagmus, diplopia, oscillopia, vertigo, nausea, or vomiting due to vestibular nucleus involvement. And there is Horner syndrome, which is meiosis, ptosis, and decreased sweating due to descending sympathetic tract involvement. And dysphasia, hoarseness, paralysis of the palate, paralysis of the vocal cord, diminished gag reflex because of 9th and 10th nerve involvement, and loss of taste because of nucleus tractus solitarius, and numbness of the ipsilateral arm, trunk, or leg can be due to cuneate and gracilis nucleus involvement. Then we have total unilateral medullary syndrome, which occurs due to occlusion of a vertebral artery. It's a combination of both medial and lateral syndromes. Then we have lateral pontomedullary syndrome. Again, it occurs due to occlusion of vertebral arteries. Again, there will be combination of lateral medullary and lateral inferior pontine syndromes, which I will be discussing. Then we have basilar artery syndrome, occlusion of the vertebral artery. There will be bilateral long tract signs, both sensory and motor, cerebellar and peripheral cranial abnormalities. Paralysis or weakness of all extremities plus all bulbar musculature will be there. This is because of corticobulbar and corticospinal tract bilateral involvement. When we move on to pontine syndrome, we have medial inferior pontine syndrome. This occurs due to occlusion of a paramedian branch of the basilar artery. So on the side of the lesion, there will be paralysis of the conjugate gaze to the side of lesion. This is because the center for conjugate lateral gaze is involved, and then can be nystagmus due to vestibular nucleus involvement. Then ataxia of the limbs and gait, likely because of middle cerebellar peduncle involvement, and diplopia on lateral gaze due to abduction nerve involvement. On the opposite side, there can be paralysis of the face, arm, and legs due to corticobulbar and corticospinal tract involvement in the lower palms, and impaired tactile and proprioceptive sensation over one half of the body due to medial lemniscus involvement. Then we have lateral inferior pontine syndrome, which occurs due to occlusion of anterior inferior cerebellar artery. On the side of lesion, due to vestibular nucleus involvement, there can be horizontal vertical nystagmus, vertigo, nausea, vomiting, and oscillopsia. Facial paralysis due to sound nerve involvement. Paralysis of conjugate gaze to the side of lesion because of center for conjugate lateral gaze involvement. Deafness and tinnitus can be there due to auditory or cochlear nucleus involvement. Ataxia due to middle cerebral peduncle and cerebellar hemisphere involvement. Impaired sensation over face due to fifth nerve nucleus involvement. On the opposite side, patient may have impaired pain and thermal sensation over one half of the body due to spinal thalamic tract involvement. Then we have medial mid-pontine syndrome, again due to paramedian branch of mid-basilar artery. On the side of lesion, ataxia of the limbs and gait due to pontine nucleus involvement. On the opposite side, there will be paralysis of face, arm, and legs due to corticobulbar and corticospinal tract involvement. And because medial lemniscus involved, touch and proprioception is variably involved. And we have lateral mid-pontine syndrome, which is due to occlusion of short circumferential artery. On the side of the lesion, again, because middle cerebral peduncle is involved, there will be ataxia of limbs. And in addition, paralysis of muscles of mastication can be there because of motor fibers of fifth nerve is involved. Impaired sensation over the side of the face due to sensory fibers of fifth nerve involvement. On the opposite side, again, there can be impaired pain and thermal sensation due to spinal thalamic tract involvement. And we have medial superior pontine syndrome, again due to paramedian branches of upper basilar artery. So on the side of lesion, there will be cerebellar ataxia due to superior middle cerebellar peduncle involvement, and internuclear ophthalmoplegia due to medial longitudinal fasciculus involvement. And some may have myoclonic like syndrome, palate, pharynx, vocal cords, or respiratory apparatus face or oculomotor apparatus can be involved. The location is often uncertain. Central tegmental bundle dentate projection of the cerebellar or the inferior olivary nucleus can be involved this way. On the opposite side, there can be paralysis of face, arms, and legs due to corticobulbar and corticospinal tract involvement, and rarely touch vibration position sensor affected because medial lemniscus involvement. Then you have lateral superior pontine syndrome, which is syndrome of the superior cerebellar artery. So on the side of lesion, there is again ataxia of limbs and gait falling to the side of lesions because of middle and superior cerebellar peduncles, superior surface of cerebellum and dentate nucleus involvement. Again, because vestibular nucleus is involved,